and the executive team and founder. He's a pediatrician in private practice for the last 23 years, and he holds faculty and clinical medicine appointments in several Chicago area teaching hospitals. He's board certified in pediatrics and neonatal and perinatal medicine and licensed in the state of Illinois. His interests include technology as it relates to medicine and telemedicine, as you'll hear today, and he holds several telemedicine committee posts in various national and local organizations. Dr. Deshpande has written several peer-reviewed articles pertaining to telemedicine and practices in the telemedicine community. And in 2013, he formed and managed a corporation, Galena Scientific, and developed the Osler device and the physician platform, which received FDA clearance in July 2017. So while he won't be speaking about that today, he'll be talking about it in our spring conference where he talks about the specific device and that innovation. And today he's going to give us an overview of telemedicine, coming of age and going global. So thank you, Dr. Deshpande. I'm going to turn it over to you now.
Thank you, everybody. Thank you, Supriya. Thank you, everyone, for joining today. Good afternoon, everybody. I'll share my screen. I hope this is the technology lecture, so I hope that the technology works well. I hope that you're able to see my screen and able to hear as well. So I'm going to go ahead and start my lecture. So telemedicine, coming of age and going global, pre-COVID and post-COVID scenarios and reimbursements. As Supriya just said, I'm a pediatrician in private practice. I'm not a technology guy, neither I'm a billing expert. I'll be focusing primarily on outlines for some of these things, as well as focus primarily on how to develop and how to conduct a telemedicine program, and more importantly, how to conduct a successful televisit in the office. And that probably will be my focus for the day. So next, as Supriya said, I have a corporation which builds telemedicine solutions for healthcare providers and healthcare institutions. I will try to stay out of any commercial bias, including my own product and technology today. And I certainly want to make sure that I give you a general broad outline of telemedicine, history of telemedicine, how telemedicine came about, where are we today, and where we go from here. I'm also going to talk about global initiative, do's and don'ts of a telemedicine visit, recent changes in regulation and reimbursement pre and post COVID. So what is telemedicine? It's a use of medical information exchanged from one site to another via electronic communications to improve a patient's clinical health status and to manage it. This is the definition by American Telemedicine Association, and there might be many other definitions which are similar to this. Telehealth, on the other hand, is a broad term which is used to deliver health-related services and information that support administrative activities, education, teaching, and other activities that may involve use of technology. A two-way real-time interactive communication between a patient and a physician at a distant site through telecommunication equipment that includes at a minimum audio and or video equipment is the definition for CMS. As you might know, some of these definitions may have changed a bit given the fact that obviously COVID has changed it and it has accelerated the pace of development of telemedicine in general.
Hi, Dr. Deshpande. I'm so sorry, this is Supriya, I'm interrupting, but can you change the view to full screen? I think for some people, it's a bit small on the presenter view.
Okay.
All right, sorry about that, thank you.
No problems. Is it better now? Is it better?
Yes, that's much easier to see. Thank you.
Okay, no problems. You're welcome. So we'll be defining certain terminologies in telemedicine, and some of them could be overlapping. At times, some of them could be confusing. So the most common terminology that we use is remote patient monitoring, which is digital information to collect health-related data, analysis, interpretation, and management, and action taken upon themselves. And this is probably one of the most commonly used terminologies even before pre-COVID eras, because there were reimbursement codes by CMS for this particular technology. The second one that's commonly used is store and forward, which is digital data, images sent via email or similar formats in a very secure manner to patient and back and forth. E-consults is by definition asynchronous provider to provide communication, provider to provider communication via secure means such as electronic health records, and that is defined as e-consult. E-visit, on the other hand, is a very broad term, patient and physician communication. M-Health specifically stand for use of mobile phones, personal digital assistants, monitoring devices, and last but not the least, teleeducation, which encompasses process of learning, which is mediated by telehealth technologies. To stress these two terms, which is synchronous and asynchronous, synchronous is a real-time audio-video communication that connects physician and a patient in two different geographical locations. And store and forward is a part of asynchronous, whereby that collects images, that collects data, that is transmitted over in a secure manner and interpreted at a later date or date. Remote monitoring tools that collect data, such as weight, blood pressure, hemoglobin A1Cs, sugars, and blood pressures are considered asynchronous mode of communication. Online digital and brief checking furnished using communication technology is also defined as asynchronous communication. Besides the fact that during COVID era, we have to make sure that we maintain social distancing, we maintain that we maintain health of our patients and also our office staff. Access to overcome geographic distances, overcoming transportation barriers, maintaining a high quality of care that otherwise would not support any specialties, especially in rural areas where there is physician shortage, rapid responses to medical needs, and comprehensive care by the most appropriate, least costly provider are some of the aims for potentials for telemedicine solutions. Interestingly, this was discussed almost in 1925, whereby a physician is looking at a patient remotely by using radio technology. And some of us might be aware of the Jetson, which are the 1962 orbit city, whereby you can see this physician looking at patient's mouth via television. History of telemedicine goes long way back, all the way from 1879, when the telephone was invented in 1876. There is an article in Lancet about a doctor listening to heart sounds via telephone in a hospital, all the way up to 2020, over a period of last 120 years worth of span, whereby we have used mobile devices, computers, personal digital assistants, and telephone apps. And telemedicine industry seems to be a rapidly growing industry, especially post-COVID era. As a lot of us are aware, especially in the public health sector who study health statistics and finances, we know that 18 to 20% of GDP, one of the largest in the country, in the world, is spent on healthcare. And US does not rank any top in the last 20 to 25 countries which are fully developed, just like United States. And as you can see, a significant amount of burden for healthcare cost can be reduced by telemedicine, as we will see down the road. There are four different types of communications. One of them is direct to consumer. Second is direct to patient. We talked about teleconsultation and store and forward technology earlier. These terms can be overlapping, and especially in post-COVID era, I believe that these terms are probably interchangeable at this point in time. So we have to take that into context. Direct to patient is primarily in an established physician's office, whereby a patient communicates or the physician communicates via electronic medical record or an app or a link. It is primarily provider driven. It is scheduled on demand. It involves primary or specialty care. It requires home devices may be used, such as cell phone, and it also incorporates remote patient monitoring or remote home monitoring. Whereas on the other hand, direct to consumer is patient driven. It is usually app based. It is on demand, typically acute care, and the payment model usually is cash or insurance. Whereas for direct to patient care, the payment model usually seems to be related to insurance only. There are various types in which telemedicine can be used. One of the common ones that we have often come across is telemedicine in the emergency department. The commonest application of telemedicine technology is in telestroke area, whereby there is a hub and a spoke model, whereby in rural areas, there is usually a remote monitor or a robot, which is usually placed in the emergency room, whereby they will be communicating directly with a hub hospital, whereby there is a neurologist who is managing strokes. And it has almost become a standard of care in certain communities for telestroke management. Initiating early resuscitation, especially when an emergency room gets a call from the emergency transport EMTs. And we want to make sure that the patient is managed well while the patient is being received in the emergency room and avoid common pitfalls. Also help in determining health course of action, avoid necessary transfer or justify a transfer to a tertiary hospital. Help determine appropriate mode of transfer, such as ambulance, helicopter, or a fixed-wing airplane, depending upon the need when they contact the hub hospital. And that is also very standard practice in a lot of rural hospitals. It also allows nurse-to-nurse reporting. It also allows physician-to-physician exchanging. And it has been shown to increase satisfaction, result, and perception of care that is delivered in the emergency room. Outpatient telemedicine, besides outpatient visits for primary care, it can be used for procedure-assisted consultations, EEGs that can be done remotely. Ultrasound images can be transferred via store and forward. Echocardiography has been used extensively in telecardiology, as we will see down the road, for management and diagnosis of cardiac lesions. School and child daycare center is pretty straightforward, whereby there is a hub and a spoke model, whereby a daycare center may have a telemedicine technology communicating with the physician, and or a school having remotely located consulting with the physician or a healthcare provider via telemedicine equipment to the main hub. Long-term care facilities also is an interesting model whereby telemedicine can be employed, both in terms of store and forward remote patient monitoring technology. Mobile and portable remote sites, as we will see, which have been established in various countries across the world. Telemedicine vans, EMT, scene, triaging, and transport. And last but not the least, as I mentioned, is home health monitoring for diabetes, asthma, obesity, post-transplant care, and technology-dependent cares. Dr. Bernard Harris is an astronaut, and as you all very well know, NASA developed the technologies in 1950s and 60s for telemedicine. The picture at the bottom shows that there was a mine disaster in South America some time back, and telemedicine technology was used extensively to help the miners before they got out of the buried mine. Use case scenarios, obviously one of the common ones that we have seen is inpatient consults. This can be both for primary care diagnosis as well as for consulting specialists. Post-discharge follow-up of patients, whereby you give them instructions, medication reconciliation, and there are studies which prove that it is not only cost-effective, but also a great patient satisfactor. School-based clinics, sibling visitations, care conferences between different hospitals, again, a hub and a spoke model or a tertiary hospital is something that we can use. Interpreter services, and last but not the least, physical, occupational, and speech therapy services are being extensively used, especially post-COVID era, by using various platforms that we will come across in next few slides. We also have an interesting slide at the end of the presentation whereby there is Santa connection, whereby we have visited the Santa electronically, and you'll see a picture of that in a moment. International telemedicine. This is a global health initiative arranged by UIC, and I wanted to make sure that I give importance to international telemedicine. So Swinfin Charitable Trust is an email-based system for store and forward, which was established in 1990s after the Swinfin Charitable Trust. This was one of the first email-based system for store and forward type of technology, whereby physicians who are at the hub model will be communicated by different patients and different providers from many countries. I believe that they have reached of about 35 countries, and the medical question will be answered usually within 24 to 48 hours. We are all familiar with Doctors Without Borders, who extensively use telemedicine technology for their patient care. I want to particularly mention ECHO, which stands for Extension for Community Health Outcomes, which was founded by one of the physicians, Dr. Arora, which uses technology to educate primary care physicians and patients. And this has been very, very successful in about 35 countries with about 400 hub and spoke model. This was started in late 1990s, 2000s for hepatitis C management, but now it has been extended to other chronic diseases as well. And this is considered as a role model for collaborative technology and cost-saving measures. Shriners Hospitals uses telehealth program extensively to manage orthopedic care, cerebral palsy, as well as for cleft lip, cleft palate management. American Telemedicine Association and International Society for Telemedicine and eHealth have extensive partners in many developing countries, and also a lot of social work projects that are going on in various countries, including South America, as well as in Africa, and then they sponsor some of those initiatives. Telemedicine in India has been very interesting. Telemedicine is practiced in India for almost since 2000. It lacked regulations and legal framework. In March 2020, after the COVID epidemic, the central government decided to establish comprehensive telemedicine guidelines, which have been published extensively. And they also initiated a Digital Health India Association to collate and to make sure that we implement telemedicine framework needed. As you can see, social distancing is very difficult in India and a lot of countries whereby there are poor resources. Also, it is important to know that a lot of these patients and people lack the basic hygiene, including low socioeconomic status, whereby they need to be cared for extensively by a different technology, because as you may know, that a lot of times there is no insurance company paying for the expenses, and patients and parents have to foot the bill, which can ruin their finances. So establishment of such a Digital Health India Association framework will certainly facilitate telemedicine in developing countries, and India being the prime example. Some of you may be familiar with an app which was recently developed and distributed widely across the mobile network in India. I'm going to come to that in about a minute, which has launched to secure the health of citizens by real-time information and contact tracing. You might be aware that there is an app called Arogya Setu, which has to be downloaded by every Indian citizen if they want to move around in India. And it is very important that they have this app on their cell phone. This uses Bluetooth and GPS technology, which creates an anonymous encrypted social graph of patients' interactions. And you need to have a green check mark before you can move around in India, especially by train or by plane, or if you want to change states, then I think it is important that all the citizens have this particular app on their cell phone. Coming back to South America, I mentioned that there have been times whereby some of those things have been deployed, especially in Colombia, Peru. And you can see this particular ship here, which is basically a command ship for telemedicine direction. And this can certainly be used in various calamities, such as earthquakes and typhoons seen in Southeast Asia. There are significant barriers to international health, and obviously the picture is not very rosy. Political for the one, technology barrier, availability of internet, for that matter, electricity, speed of connection, upward and downward speeds, personal training, and most importantly, ensuring proper standards can be significant barriers to international telehealth. And we want to make sure that those barriers are reduced, thereby improving poverty, improving patient satisfaction, and more importantly, healthcare for all. In Southwest Pediatrics, where I lead the televisit program, we conducted a 6-month study which started back in January, even before the COVID hit, because we had recognized the potential of telemedicine in our office. So we started this project with 2 physicians. I run a 6-physician practice in Palos Park in Mokina. We had 1 office manager to help and manage the appointments. We scheduled 1 day per week, about 2 to 3 hours for televisits. Televisits were primarily extended for medication management for ADHD patients, as well as for anxiety and similar psychiatric disorders. Televisits were available for patients who are doing very well, they were stable, and they have no current medical issues. And we generally request parents to be along present with the patient unless the patient is 18 years or above. This is how we use, luckily we have an EMR which basically extensively integrates with our televisits app. This is our office manager who has helped us tremendously in terms of running a program. And I highly encourage all of you to make sure they have a staff which is very supportive, because they help in setting up appointments. They help in sending the email or text reminders to various patients, and they make sure that if there are any glitches in the technology, then they help you out. And we have trained 2 staff members, one of them from admin and one of them from a medical background, to make sure that we conduct these visits very, very successfully. And our patient satisfaction has been tremendous. This pilot program was changed to an active program as of end of March, whereby all 6 physicians are participating in this particular program. It has been immensely successful, and we have been able to get reimbursed for most of those visits. We have conducted over 400 visits in last 4 months. Please remember, it's about patient. It's never about technology. We want to make sure we define goals. We want to make sure that we engage champions and find small pilot group. I personally believe in what we call as a PDSA cycle, whereby we tend to do planning, do, study, and act. And we want to go act and check the results within a couple of months and make sure that where we have gone wrong and we have time to change that. I'm also happy to discuss this with any pediatricians in the area, and I've already extended our office help to pediatricians in the area during the COVID time to make sure that our patients do well with technology. These are various devices that can be used inpatient and outpatient. They range anywhere from $200 to $20,000. Some of them are inpatient cards, some of them are mobile devices, and of course, a cell phone app, along with the necessary medical devices are available in the market. Cost, training, and their effectivity is a matter of personal choice at this point in time. And I'm happy to discuss some of those options with you down the road if there are any questions. March 2020 changed everything for telemedicine. It basically got telemedicine into the forefront of everybody. Televisits and telemedicine became common terminologies used by every patient, every media network, and every company, including technology companies. So remember, only constant is change. So we'll discuss before COVID and after COVID briefly, and then I'm happy to discuss some other aspects about televisit. As you can see, in a healthcare institution, which is a training institution, the healthcare visits for telemedicine jumped from almost 100 visits per day to more than 2,200 over a period of 24 days since March. And some institutions have reported almost 5,000% increase in telemedicine visits, either televisits or e-visits. The major changes that were primarily brought were in terms of regulations, in terms of reimbursements, in terms of licensure requirements, and in terms of relaxing the rules for managing patients. So they now allow, CMS now allows, as of March, a patient's home as an originating site, allows patient providers to use normal point of service as an office visit when providing services from home. Most of the CPT visits are eligible for telemedicine, and there are more than 200 codes which have been around for telemedicine purposes. They consider it parity between in-person visit and telemedicine visits. Cost sharing for services related to COVID-19 have been waived, and there is an option for telephone as well as a televisit with significant HIPAA waivers. We encourage practices to develop their own technology, make sure that their staff and their physicians are educated, triage patients and train patients to the office practices. We have developed extensive booklets as well as emails to help patients requiring their computers to be checked, as well as making sure what technology they need to use to have a successful televisit. And then we have the clinical protocols for telemedicine versus in-person visits. The common pitfalls are, we want to make sure that when we are calling a televisit as a parity of regular face-to-face visit or an in-person visit, we need to meet standard of care. We want to try to do as much virtual examination as possible, develop a robust checklist for your office and your practices, depending upon the specialty or primary care that you work in. Make sure that patient follow-up is adequately documented in the chart, and a timely documentation of start time and ending time is very much necessary if you want to bill for your time. We have a consent that we have developed, and that is incorporated as a part of our televisit package. And patient has to sign the consent at the time of every televisit that they agree to. And we have developed that extensively in conjunction with certain tools that we have used. So keeping the high quality, and we call it a website manner as compared to a bedside manner, and that's a terminology that we use commonly. Make sure that you're dressed professionally. Try to minimize ambient sounds or any other distractions such as cell phones, email popping in and out. Make sure that your webcam is working appropriately, including audio as well as video. Try to look directly into the camera rather than at the screen. Introduce yourself. Make sure that you confirm patient identifiers such as name of the patient, date of birth, and telephone. These are the 3 identifiers that we commonly use to identify the patient as well as their caregivers. We want to make sure that we are very transparent with families in terms of what that visit can achieve. We want to make sure that the physician does their homework before before the visit is prepared. Try not to complain to the patient and try not to sound bored on that televisit, whereby saying that we don't have a choice and we are using this televisit, because that makes the patient depressed and also frustrated because they're also trying to use a new technology. There have been times whereby I have to adapt to a telephone visit rather than a televisit because the technology did not work or the internet bandwidth was not appropriate. Please remember that every visit cannot be and is not a televisit. Pick what works for your patient practice, for your patient population and your practice. And make sure that you document all the information that you generally have during in-person visit. A common question that has been asked in the past has been, what platforms can we use? And this is one of those March 2020 COVID allowance, whereby we can use a platform which is typically called as a non-public facing platform. And besides the regularly available platforms which are online, such as your EMR, Apple FaceTime, Facebook, Messenger Video, Google Hangout, Skype, and Zoom, and medically available commercially dedicated platforms are acceptable forms of patient communication. What is not acceptable is these are called public-facing platforms. So I highly discourage from using TikTok, Twitter, Facebook Live, and Twitch for any patient communications. Though HIPAA rules have been relaxed, I've used text messaging on an infrequent basis. Our hospital provides a very safe-based app and a telephone service that we can call patients from, which is HIPAA compliant, and we try to use that service extensively, and those are available in the market as well. Cybersecurity. It is very important as healthcare institutions and primary care physicians, including specialists, make sure you protect your data from phishing scams, make sure that your data is well protected. Connected devices, gadgets, printers, copy or store data, and they're all very high risk of cyber attacks. High-speed internet, some of this is always on, and we need to build in firewalls and make sure that your Wi-Fi hotspots are protected. We tend to take these things for granted, but when an attack happens, either a malware attack or a phishing attack, then I think it could be a problem, and that may compromise your patient care and quality of the service that you deliver to patients. Remote access, VPNs, especially if you're using EMR from home and other places, is extremely important. All of us are familiar with accounts and password, multi-system authentication. Make sure that the operating system patches are regularly installed. You need to hire a professional IT service before you install some of these things. I'm sure that a lot of us are probably dealt into technology, and the more you delve into technology, you realize that there are a lot of pitfalls and it can get pretty complicated. Please make sure that you have antivirus software which is updated on a regular basis. Macros are prone for viruses, and also make sure that any software that you use privately has plugins for various functionalities in the office is also safe for you to use. Coming to the important topic, which I'm sure all of us are waiting for. So typically, we use a site 02 as a place of service, which was not previously allowed. And we check payer contracts to make sure they want 02, or they want the point of service that defines the location, such as 11-office or 11-hospital. Originating site used to be certain healthcare centers. Now it has become home as a regular site for billing. This is an extensive, detailed slide, and what I want to do is point out to this particular section whereby we can use synchronous audio and or video. The visit duration can be same as in person. Eligible physicians can certainly apply for that. Pre-existing patient relationship is no more required. Paid in same in-person equivalent, answer to the question is yes, there is a parity now. And options to waive patient cost sharing for COVID-19 patients, yes. And allowed patient originating site, any, rather than a rural healthcare center or a hospital. So we talked earlier about remote patient monitoring, and this is one of the important terminologies that you will hear, especially when you are using and taking care of adults, which is very important. It can now be furnished for both new and existing patients. Consent required once annually and can be obtained during visit. And remote patient monitoring can be used for patients with both acute and chronic conditions. And these are various codes from 99453, which installs initial device setup and a one-time patient education, all the way up to 99458, which requires monthly clinical monitoring and support at this point in time. These are the general reimbursements by technology, and by no means a way to this can be applied regularly. So for a audio only or a telephone visit, the bill can be from reimbursement can be from $15 to $43. Audio plus video, which is new patient visit, the reimbursement can vary anywhere from $53 to $245. And for an established patient, it can anywhere be from $26 to $170. As you can see, remote patient monitoring plus audio plus video, there are various charges and various codes that can be inbuilt into this device connection, as well as making sure that you contact your provider, you contact your payer, as well as different states and different contracts that you're contracted with, so that the rates may vary from time to time, and the rates may vary from region to region. This is, I mentioned to you earlier about the Santa connection, and we use this extensively at Advocate Children's Hospital. I'm sure come this winter and come Christmas, we'll probably using this for a digital Santa to visit patients in the hospital. Future of telehealth, it is here to stay. Telehealth home visits will become a norm. New handheld devices, smartphones will become smarter. There will be incorporation of AI along with de-skilling of various specialties. We have extensively seen that telecardiology, telepsychiatry has definitely flourished over the last couple of years, especially given the fact that there is significant shortage of psychiatrists and mental health care in rural areas, including the United States, where the waiting times can be as long as 6 months or more. It is very important that we do that and use these protocols. As I mentioned to you earlier, it is very important for us to try to make a physical examination. We request patient or caretakers to make sure that they take vitals, and as much systemic examination as possible needs to be documented so as to make sure that we have a complete telehealth visit. We think that research protocols will be designed around virtual trials, and all the data and collaborative trials will be definitely go virtual. Medical students, which will not only learn virtually, but they will also practice virtual medicine. It is the world by saving cost, by making sure that we have quadruple aim, which is satisfied, which is of best patient care, patient satisfaction, and making sure that there is a low cost associated with this to bring the cost curve down. Certainly, telemedicine technology has helped us in trying not to only curb infections, but also try to flatten the curve that we talk about over the last 3 to 6 months. And I hope that it will continue to happen. It is very important, like any medical tool or intervention, that we must be meticulously studying some of these technologies, make sure they are wisely developed and thoughtfully implemented in a manner so that there is no abuse of these services taking place, such as overbilling or using these services when they are not indicated. The ultimate goal is making sure that a visit is same as a televisit, and we want to make sure that make the term telemedicine obsolete down the road so as to have high quality of care, which is equal to in-person care. I thank Supriya, Dr. Vora, Chelsea, Allison, all of you. Thank you, Dr. Kathy Webster, Dr. James Marson, and Brian Burke, who allowed me to use their slides. Thank you for my office staff for help with data for the pilot study. And I thank Piyush Kedia of EMP Claims providing me some billing help as well as formatting for this particular slide. And this is me doing a televisit in the office. If you have any questions, you're welcome to send an email to me down the road. And thank you very much for your time. I hope I have concluded on time, Supriya, so up to you. Thank you very much.
Thank you. That was great. Thank you so much. Yeah, and you kept us on time, so that's wonderful. So yeah, if you have questions, you can put them in the chat box, or if there aren't a lot of people going at once, you can unmute yourself and ask the question directly. Well, I'll start with a question then, because yes, I'll start with the question about, I think this brought up to me, I'm not very technologically savvy, but I think it identified a lot of interesting things, especially when you showed that slide about how the telemedicine visits had just kind of taken off exponentially with COVID. And,
right.
What is the sense with the national trend, and whether that's, what is the equity and availability? So we're seeing with COVID, the racial disparities, that the people who are most at risk are being the greatest affected by it. And what is the equity in the availability of telemedicine and telehealth?
I think that's a great question. I think that continues to be a problem. I briefly alluded to rural America and certain areas where the broadband internet connection is still significantly lacking. And I've got studies which basically have said that anywhere from 40 to 50 million Americans lack still today broadband services, which are usually necessary for delivery of healthcare. That continues to be a problem. And I'm hoping that especially the same problem we are realizing now in Chicago Public School, whereby the kids are trying to take education online and there is no internet connection. I have seen those reports on TV over the last few days since the Chicago Public Schools have started a week ago. So that continues to be a problem, which we call as a last mile challenge. And last mile challenge continues to be a problem in terms of broadband services, poor connectivity and internet. For me personally, when the internet is not working, I've used telephone extensively. But to your point, Supriya, that needs to happen rather quickly. We need to make sure that we make telemedicine and internet more of a commodity rather than only accessible to certain individuals. So that continues to be a socioeconomic problems bothering us in America. And I think you had given me an article about Zimbabwe, whereby education and lack of connectivity is still lacking. So we want to make sure that our population is educated well. We want to make sure they have the right resources and the right tools to take care of these telemedicine services.
Thanks. That's really great to put in perspective as we develop this. So we have another question from the audience with Dr. Ziegler. If you want to go ahead and ask.
Yes, yes, Doctor. A very interesting presentation. On one of your slides, you referred to some of the barriers, one being political. And I'm thinking, when is that an issue? Is that more of a global issue?
Yeah, I think it's more of a global issue in terms of whether somebody wants certain services in a particular area versus others. So I was thinking more of a referral to a global pattern, whereby there should be a commitment from the government to make sure that these services make it happen. Like, for example, just to give you a very positive example of a way whereby current Indian government has basically installed that app on everybody, which was given free of charge to everybody. And that has been a significant positive thing. But I think political battles continue to happen over the entire world in terms of what services to do. And there might be certain other vested interests that may affect telemedicine globally.
All right, thanks. We have a question from Sachin Moge. Sorry if I mispronounced it.
Yes, Sachin, go ahead.
Dr. Deshpande, thank you. So I can imagine, I'm not a physician, but I can imagine that as a physician, the touch, feel, and palpate is an important aspect of any examination. So how do you overcome this in the televisit? Obviously, the patient assumes a bit of a role as a caregiver in this sense.
Right, and I think that's a great question, Sachin. Thanks for asking that. I would say that we continue to develop different tools, which are low-cost tools, which will basically be what I call as peripheral tools, and we are constantly looking for those. At this point in time, we don't have, we are not using any tools currently, but we are constantly look out for those. And I think that touch and feel is very, very important. So your point is very well taken. We are, what happened is post-COVID, what has happened is that we are basically flying a plane and trying to repair it too at the same time. So I think this will take some time to evolve over a period of time. But at this point in time, we are relying on patients, parents, as well as the patient themselves to try to give us as much information as possible, including the vitals. But as the cost of some of these tools comes down in near future, probably next couple of years, I think we might be able to do that more effectively. So.
Thank you.
We are currently not using any of those technologies in the office besides televisits and telephones and using video services only.
We have a question from the audience, from Natasha Pierre.
Yeah.
Oh, I don't know if Natasha is still here, but let me get to her question. She was asking, what is a good resource to help assess patients using telehealth?
So great question. So first of all, American Medical Association has basically developed a lot of tools. So a lot of these things that I mentioned today about cybersecurity, about patient examination, and so on and so forth are available on American Medical Association website. American Academy of Pediatrics has also extensively built in tools. CMS has done a great job of updating their telemedicine protocols and telemedicine visits. And last but not the least, professional organizations such as American Telemedicine Association and Society for International Telehealth and eHealth are great resources to be used. And I have read some of those articles in the past over a period of time preparing for this topic. And I found a treasure trove of a lot of this information on these 6 or 7 association websites.
Great, and you know, one of the questions I was also going to follow up with is that you listed the barriers for international telemedicine, and that in some of these countries that may have resource constraints, there's infrastructure constraint with the electricity and with the internet. And I am not technologically savvy, but is there a way to get around these infrastructure barriers, or is telemedicine kind of held back until those infrastructure barriers are addressed?
I think I have seen some pictures from Nepal whereby they have extensively built-in antennas over the mountains. I have seen some of these places where I showed you the boat, which basically uses a hub. And I'm also sure that you probably have heard about a lot of these big companies, such as the Facebooks of the world, which are building internet and satellites, whereby their job will be down the road to provide internet to some of these developing countries at a cheaper cost. So I think efforts are being met. And to piggyback on your earlier question, I think that needs to happen pretty soon. And now that we have, because of post-COVID, I think a lot of governments have probably started taking interest in telemedicine and technology, and I'm sure it's only a question of time. And I'm very, very optimistic and very positive about these technologies reaching to the needy and the poor. And you mentioned about low and middle socioeconomic class. So I think it's a question of time. We want the internet cost to come down as well, because broadband, even in Chicago, is not very cheap. And I think it's very important that we harness these technologies to our advantage so as to make sure we build a global village for technology and telemedicine to deliver a low cost care at a very high quality.
Yeah, that's great. I think like keeping that eye on, you know, the equity and ensuring that it reaches the populations who have the least access to care. So I think that's, yeah, I really hope to see that, how that expands.
Thank you.
we have a question in the audience from Anthea. Anthea, do you want to go ahead and ask?
Yeah, thank you. So I'm just wondering about the feasibility of using Wi-Fi boosters in areas that have potentially connectivity issues to make the existing internet infrastructure stronger for the purpose of telehealth.
I'm sorry, Anthea, we lost you, so I'm going to read your question from the chat box. So Anthea is asking, is there potential for the use of hotspot Wi-Fi boosters in rural America to boost existing internet coverage infrastructure for the purpose of telehealth?
A short answer to your question is yes. A long answer to the question is even for Wi-Fi boosters, you probably need a hub to provide that internet service. So the answer to the question is yes, and I'm sure it can be pretty, I think it's a vicious cycle. The more you do, the cost goes down. So answer to the question is yes, it's certainly possible. And there are technologies that exist which basically will create a hub and a spoke model for delivery of internet services, including Wi-Fi spots. And we can certainly rely on satellite dishes in rural areas to make sure that it happens. But again, for the Wi-Fi and the hotspots to work, there has to be a source in the first place. And that's certainly something that we need to build.
Great. Do we have any other? Oh, we have another. Oh, yeah. Thanks, Anthea. All right. If we have any other questions from the chat box. So Neela's reminding me to give another reminder for our upcoming conference series in March 19th. If you want to mark your calendars now, it's going to be a day-long conference. And Dr. Deshpande will be talking about his device, the Osler device. And I think that might also answer some of the questions about how this actually works in practice. So I know I'm looking forward to that as well. And we will be also sending out for our next talk in November on contact tracing app. And so any questions? And yes, there's a couple questions. We've had a few questions in the audience about the availability of the slides. And yes, they will be posted. We'll send the link to the registered participants when they become available. All right.
Thank you. Thank you, everybody. Thank you, Supriya.
Thank you, Dr. Deshpande.
Thank you, your
That
team.
was great. Thank
You're
you.
welcome.